The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, and we are very pleased to be able to revisit some of the questions that have been sent in about hearing. There's been a fair amount of interest and some very good questions that have come in. I think some good discussions. We're very happy to have Adrienne Johnson and Albert Park back with us. Thanks so much for your time and your expertise. Ready to tackle some questions?
Yes.
Sure, we'll try.
All right. Any disclosures that we need to talk about?
Mine are mostly related to research. I'm a scientific advisory committee for KUOS, which is a company that, amongst other things, is developing gene therapy modalities for children with hearing loss. I also have some NIH funding. It's more basic science related to CMV, trying to understand how CMV causes hearing loss. And I also have some intramural funding through the University of Utah in terms of trying to develop some screening tools for CMV detection.
Adrienne?
I don't have any disclosures.
Okay, we'll try to get you some. Well, that'll be our...
Not necessarily.
I don't think I want any.
Disclosures, conflicts, all of the above. First question comes from Dr. Michael Metz in Newton, Iowa. As a pediatrician with 26 years of experience, much of it spent in the newborn nursery, I've had countless conversations with parents about the meaning of a hearing screen that doesn't result in a pass. I deeply respect your guests' perspectives, especially the emphasis on not minimizing the possibility of hearing loss. However, given that 80% of newborns who do not pass the initial hospital screen ultimately do not have hearing loss, I believe we better serve families by using the term refer rather than fail. This choice of language opens the door to meaningful dialogue. Your baby was referred for further testing. This doesn't necessarily mean there's a hearing loss. We'll do a follow-up test to make sure we're not missing anything. Most babies pass the second screen, but if there's a hearing concern, early intervention is key to better outcomes. Telling parents their baby failed the screen can be emotionally jarring and makes them see their baby as defective and vulnerable until proven otherwise. Is there a rationale for the language that we use? I did edit that a little bit for content.
I'll go ahead and tackle this one to start with, Albert, and feel free
Sure.
to jump in. So this is something that has been given a lot of thought in terms of words. So I first want to acknowledge that terms and the choices of words that we use are very important. Terms do have different interpretations and values based on cultural perspectives, and we should always use culturally sensitive language whenever possible. In response to this specific question of fail versus refer, again, this is something that we discuss a lot within the newborn hearing screening community. In most cases, a hearing screen is done in a medical environment, and it's a binary test. Either you pass or you don't pass. Either you pass or you fail. And using the word fail is more consistent with other medical tests that are being done. The Joint Commission on Infant Hearing in 2019 actually in their document discusses this exact scenario of refer versus fail. So just to remind everyone what the Joint Committee on Infant Hearing is, it's a group of professionals that includes the AAP, the American Academy of Otolaryngology, Head and Neck Surgery, all of the major deaf associations, all of the major audiology associations. They're professionals who get together, who review research and come up with a consensus statement that is published for evidence-based best practice. And in 2019, which is our most updated JCIH statement, they discuss this and recommend the use of the word fail because it is a very clear language. They said that refer sometimes is avoided because there is a lack of clarity and there can be confusion on what the meaning is. And it's also more consistent, again, within the medical community to use pass or did not pass or fail other than refer. There's also had been studies that have actually been done to look at this and the words that we use because it has changed over time. And historically, loss to follow-up has been a big deal with newborn hearing screening. So having a hard time getting families to come back in to follow up on their screening. And so the studies that have been done, there was one that was done at LSU, and they found that parents were actually confused by the word refer and what that meant, and that they didn't really understand. And when they used the word fail, it didn't make them think that their baby was a failure or had a deficit in some way. There was a more recent study done in 2016 by Tuller and White, and they found that there was no evidence of telling a family that their baby had failed the test that led to higher levels of parent anxiety, disrupted bonding, or caused worry. I do want to say this may not be the case for every family. There may be some families that when we use the word fail, it can cause more anxiety. And I will say that how we try to account for that is when we discuss a failed hearing test with the family. So, in fact, the pediatrician who wrote in this question gave a great example of what you could say to families. There's a great program called NCHAM, or the National Center for Hearing and Management, and they actually have online training for hearing screeners. And it's a requirement in the state of Utah that all of our hearing screeners do this training program and are certified. And they talk about the importance of scripts for hearing screeners when relaying a failed hearing test to a family. And as the director of our newborn hearing program at my hospital here in Utah, when I train my screeners, we spend a lot of time talking about the importance of scripts and messaging to family. So your baby failed the hearing screen. This does not mean that your baby has a hearing loss, but without further testing, we can't be sure. There are other reasons why a baby may fail a hearing test, but until we do further testing, we can't be sure. So it's all in messaging. So it's trying to not cause any panic for the family, but make sure they understand the importance of follow-up and the urgency of follow-up. So as well-intentioned as using the word refer has been in the past, we know it has caused confusion and led to untimely follow-up.
And at the end of the day, hats off to the providers who are going to walk people through it as well. So this is clearly a cooperative venture.
Agree. And everyone has their opinion on what word to use.
Yeah,
That's
right.
true.
And everyone just wants to do the right thing.
Agree.
And I think in general does. Next question. Could you please comment again briefly on the pitfalls of unilateral hearing loss? Why is it particularly fraught? What's the window of opportunity for correction? Which of the modalities for correction seem to have the highest risk-benefit ratio?
I'm sure both of us can answer this question too. I mean, Adrienne, you see this early on in your newborn screening. I think I see it when these kids, unfortunately, are now diagnosed with hearing loss. And then we follow these children over time. And so we get to know these families really well. We have our hearing center. And so we really work on trying to determine the cause and really want to make sure that we do timely rehabilitation. But there is some really good data. You know, one would think that if one ear is fine, that you're fine. But actually, what we have seen and what the data suggests is that's not the case. That having one ear functioning and the other ear not functioning is really a real problem for children. And it's hard because hearing loss is not something that you can physically see. And so it's very easy to sort of have this false sense of reassurance that maybe the child's going to do well. But the studies have actually shown quite compelling data that these children are likely to really struggle when they get into elementary school. Oftentimes, I think it's about a third of these children will oftentimes fail at least one grade. And so they're having difficulties with this. Half of these children will struggle academically. Many of these children end up going or requiring special education services. There's behavioral issues that we see. And I think what we think is causing this is that you really need both ears to be able to really be able to elicit or hear spatial information. So that means like if you're calling for your child and maybe that your daughter can't see you, that child needs to be able to use both ears to know where that sound is coming from. And that's really important in the school settings or even further because there's a lot of background noise, other sort of ambient sound that makes it really difficult. And really having two ears is really crucial to be able to function adequately in those more challenging situations. So maybe 20, 30 years ago, if your child had unilateral hearing loss, we would maybe observe, but that's not really the standard of care these days. These children are aggressively evaluated. We try to determine cause because actually one of the leading causes of unilateral hearing loss is either a structural abnormality or cytomegalovirus. And the issue with cytomegalovirus, which I think we talked in an earlier podcast, is these children are at risk to develop progressive or worsening hearing. So that one ear, which is functioning today, may unfortunately deteriorate very shortly afterwards. So that's one issue that we need to identify quickly. And then we really do try to amplify or restore hearing so that the hearing is optimized in both ears. So these children will be able to benefit with, again, both ears. It does depend to some extent on the severity of the hearing loss. These are children that, if they're deafened, we also even look potentially at cochlear implantation. And this has been sort of a change or shift in the field over the last few years in being more proactive in those situations.
Very helpful. Do you envision that advancing technology will build on or replace current therapies? For instance, will a current cochlear implant be improved or replaced by advances in the field?
I think in terms of diagnostics, there have been some changes. Certainly now there's an emphasis on tone burst. I guess there's always been an emphasis on ancillary testing, screening. I think unfortunately we're still dealing with acoustic emissions, mostly in automated ABR testing, though. I'm hopeful that in the future we'll have better technologies for that. I've been in practice for over 20 years, and I certainly have seen in my experience very significant changes in how we manage these children. I mean, even hearing aids, which you think aren't really going to change a lot, there's been really quite a bit of progress in terms of programmable hearing aids, doing Bluetooth compatible devices that interface with smartphones and things like that. In terms of cochlear implantation, really, there's been a lot of changes in that in terms of now we're looking at trying to provide hearing preservation techniques. There's a lot of work on what's called ECOG, where you try to do real-time measurements of cochlear function as you're placing the electrode. Now there's real emphasis on either perimodiolar or certain types of electrodes to reduce trauma. There's going to be very soon introduction by, I believe, the Cochlear Corporation for steroid-eluting electrodes, again, to address the issue of trying to provide hearing preservation. And so there's been a lot of changes. MED-EL has developed their technology in terms of trying to provide a really good synchrony between ears. So I do see that in the next years or so, there'll be progress. And then just recently, there's been a lot of really fascinating work on gene therapy with patients with otoferlin, where there have been clinical trials that shown really promising results that may, potentially obviate the need for cochlear implantation. And that may happen for more and more children with other types of genetic mutations. But again, that's where the research is going to have to come into play.
It's amazing how much things have changed even the past couple of decades. It's hard to imagine what happens going forward. Thank you very much. Next question. We've tried to start doing office-based hearing screens. The trouble is, I'm not really sure we're getting dependable results. I feel pretty comfortable calling a pass, but the fails feel hard to interpret. How can we be sure that we're getting meaningful information? Do I need to refer all the fails or refers? I just don't want to generate less than meaningful information.
This can be really tricky because you're right. A pass is easy. And when you fail on a hearing screen, there may be other reasons besides a hearing loss, especially depending on the child and the age of the child. If they happen to be fussy and moving around, and especially if you're doing otoacoustic emissions, or if there's middle ear fluid, that could potentially, cause a failed hearing screen. I would say when you're doing office-based screenings, there's a couple of things that it's really important to keep in mind. One is that the equipment that you're using is calibrated annually. That's something that's standard for our devices and something that needs to be considered. The second thing is making sure that the staff that is doing these screenings are trained and have constant training so that they know how to troubleshoot equipment. They know how to see if maybe a probe tip is blocked with wax and that's what's causing a refer. If they have a bad probe fit in the ear canal and perhaps that's what's causing a refer. And it's not truly a failed hearing screen, but it is user error or something like that. So having calibrated equipment and making sure that your office staff that is doing the screens are well trained.
That's very
And
helpful. Yes,
I
sir.
would like to add that I know it's sort of difficult if you're having a child who failed their screening. But I do think those children do require evaluation. And it may turn out that, again, this child doesn't have permanent hearing loss. But as Dr. Johnson says, this child may have middle ear fluid, and we want to address that issue because sometimes that middle ear fluid actually is a masker for permanent hearing loss. We saw that in about 10% of our children in our most recent publication on this issue. Plus, we find that these children, when they have middle ear fluid, oftentimes don't get the timely diagnostic testing. And so I do think that it does warrant an evaluation in those situations. We pick up sometimes other abnormalities too. I just wanted to add that to what Dr. Johnson already had mentioned.
And I will say too, a failed screening is a failed screening. Even if you think, well, maybe the child was being a little wiggly or maybe this or maybe that, I would always err on the side of sending him for a diagnostic audiology evaluation so that we're not wasting precious time. Again, this kind of goes back to the question we answered earlier, is that our screening equipment does not tell us why a baby failed or a child failed a hearing screen. It just says that they failed. So when they do get sent for a diagnostic evaluation and we're doing a test battery, we're able to get more information to make that determination. So I would err on the side of caution and send them for an audiology evaluation.
The implication of a child with permanent hearing loss and not providing timely diagnostic or treatment to me is devastating. You only have one chance. You have a limited window for you to make an impact. And if you really miss that window, and this happens, unfortunately, even in this day and age, it's tragic. It's tragic for the child. It's tragic for the family. Oftentimes we can't catch up. So I think it's really important to be proactive. You get this false sense of security if you find these children who fail, then go on to have normal hearing. But we don't want to miss the ones who really need the timely treatment.
And one more comment I want to make is that we should also be taking caregiver concern for a change in hearing very seriously, as well as what a child is reporting to us. Unfortunately, I've seen several cases where kids report they're having a hard time hearing, and it's like, well, next time you come in, we'll see if it's gotten any better. Or we'll check in with you in 3 months. If you ever have a parent who's coming in and they're concerned about their child's hearing, that alone is enough for a referral for a diagnostic hearing test.
Very helpful. And on a related note, from Sarah Wiersma in Scottsdale, what's the most economical hearing screening modality for a very small practice? Are there any apps that have validity for pure tone hearing screening that can be used with standard headphones?
I would say if you have a practice where you're only going to get one type of hearing screener, I would opt for an otoacoustic emission or OAE screener. That way it can work from birth through childhood, where if you opt for something like pure tone screening, that really only works for kids who are 4 years developmentally and above. So if you could only get one piece of equipment, I would go for an OAE screener. As far as the app goes, this is something new for everybody and something we don't know a lot about. AP recommends, their recommendations don't explicitly mention smartphone apps, but it clearly promotes objective, validated technologies. So there is some current research that's being done on these smartphone-based apps, but there's nothing yet that tells us that we can use it in place of the current technologies that we have. Audiometers need to be FDA approved. They need to meet ANSI guidelines. And because they are classified as a medical device, so they go through a rigorous review to make sure that they're meeting all of these standards. And we just don't know yet about these phone-based apps. So you can get a screening audiometer for around $1,000, and an OAE equipment can be anywhere, just the screenings, maybe between $3,000 and $4,000, which is economical considering how many kids will get screened on that. So I would think of apps at this point as more of like a hearing awareness tool, but not replacing hearing screening in a pediatrician's office.
Very helpful. Any other things either of you would like to share before we're done today? Next question. When patients are discharged from the NICU, often a repeat hearing screen is recommended at 12 months. Can we talk about the reasoning for the repeat screening at 12 months? I also am aware of the ototoxicity associated with the commonly used antibiotic gentamicin, which is given out like candy in the NICU. Can we talk about the incidence of gentamicin-induced hearing loss? Should all babies who receive gentamicin be screened at 12 months, or should that be done even sooner? What about babies who only receive 2 doses? What's the best process to go through to ensure that these babies are screened appropriately at 12 months? Who should do the screening? And is there a particular test that should be done?
So I'll start this out. And again, Albert, feel free to jump in. We actually recommend for babies who have been in the NICU for 5 days or more, we recommend a diagnostic hearing test at 9 months of age, not 12. So
Okay.
we want to see them earlier than 12 months at 9 months of age. And the reason for this, well, there's a couple of reasons. One is there's a lot of risk factors that we're aware of that babies can have that put them at a risk for either a progressive hearing loss or a delayed onset hearing loss. And our 9-month follow-up is our safety net to catch those kids. We also know, we talked about this, I think, in the very first podcast we did, that hearing screens can miss some kids with hearing loss and can miss some minimal or mild hearing loss. So that 9-month follow-up is very important to be our safety net. The follow-up does need to be with a pediatric audiologist. It's not a screening at 9 months. It's a diagnostic test so that we can catch those more mild hearing losses if they happen to be missed at birth, or for those late onset or delayed hearing losses that we can catch those then. In regards to gentamicin, this is a really tricky one. One of the questions was, should all babies who receive gentamicin be seen again? And the JCIH document that I talked about before, their recommendation is if you have been on aminoglycosides for 5 days or more, you should have a hearing test at 9 months of age. Any dose below 5 days just is the regular surveillance with the pediatrician. But 5 days or more, it is a risk factor for a delayed onset hearing loss. It's really difficult to parse out the incidence of gentamicin-induced hearing loss because a lot of these babies have not only been on gentamicin, but they were born with low birth weight. They've had mechanical ventilation. They may have a syndrome that's associated with hearing loss. So it's really difficult to parse out what amount of hearing loss is due to gentamicin, what amount is due to this, and what amount is due to that. So that 5-day NICU stay, a 5-day dose of aminoglycosides is enough to warrant a 9-month follow-up. In regards to what's the best process to ensure that they're tested at 9 months, that's really difficult, and it depends on your medical system. It depends on the state where you're at. This is where it's really important for pediatricians to be aware of risk factors that babies have for hearing loss. And I would say if you're going to know one risk factor, a 5-day NICU stay is one to just be very aware of. If a baby has been in the NICU for 5 days or more, please ensure that the baby has a hearing test at 9 months of age. So some hospitals can send out reminders. Some health departments throughout the country, when they know babies have been in the NICU, will send out a reminder. But it's a team effort when we're talking with families to make sure that they're aware of risk indicators and knowing that hearing can change over time.
What's the procedure in Utah?
Hospital by hospital.
Okay.
It
So there's
really
not a standardized health department approach.
Exactly. And every family who has a hearing screen done in the NICU in all of our hospitals in Utah, if an audiologist doesn't talk to them face to face, they receive a handout that has this information on for them. I know at our hospital, we try to talk to every family. They're given a handout, and then upon discharge, our medical team goes over with them the importance of a 9-month follow-up.
A lot to do.
There's a lot.
Yeah. Yep. Well, again, thanks so much for your time and expertise. Thanks for taking the time to address these questions today. And thanks for all you do in taking care of kids. Hearing is so important, as with vision, it's something that we want to do everything we can to make sure that children have every advantage.
Thank you, Paul.
Yes, thank you very much for the opportunity.
All right. And to our listeners, thanks so much for listening. We'll plan to talk again next week, and it'll be another topic. Thanks for listening. Tell your friends, and we'll see you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.